right? Uh-huh. 1 minute.
Дорогие коллеги, добрый день. Good morning, everybody. Yeah. I hope all is fine here after our party. Yeah. Okay. So we will start. Okay. Yeah. I hope this day is also excellent and very interesting for our participants and for us also. Okay. Start.
Okay. Следующий закладчик у нас тотальная резекция функциональных аденом гипофиза Ючи Нагата.
Okay.
Пожалуйста.
Good morning, everyone. My name is Yuichi Nagata from Nagoya University. Today's my topic is supratotal resection for functional pituitary adenomas. Transphenosal surgery has become the first-line treatment for almost all functional pituitary adenomas except for prolactinomas. However, a complete tumor removal at cellular level is needed to achieve optimal endocrinological outcomes for functional pituitary adenomas. In this point of view, complete tumor resection with the extracapsular resection technique has been reported to maximize the effectiveness of TSS for functional pituitary adenomas. This is a case illustration with a patient with Cushing disease, which was treated by endoscopic transsphenoidal surgery with the extracapsular tumor resection technique. This is a operative video, and in this case, a well-defined pseudocapsule was intraoperatively detected. So the tumor was circumferentially dissected from the surrounding normal tissue at the outer layer of a pseudocapsule, and complete tumor, extracapsular tumor resection could be achieved. However, not all functional pituitary adenomas have a well-defined pseudocapsule, and extracapsular tumor resection technique is not always available in all functional pituitary adenomas. So, radical tumor resection technique is needed for functional pituitary adenomas without a well-defined pseudocapsule. This is our surgical algorithm for functional pituitary adenomas. When we perform a transvenosus surgery for functional pituitary adenomas, first we try to find a pseudocapsule. When a pseudocapsule was intraoperatively detected, extracapsular tumor resection is attempted. Once the extracapsular tumor resection is achieved, additional resection of the surrounding normal tissue is not performed. However, when the extracapsular tumor resection cannot be achieved because the pseudocapsule was fragile or no pseudocapsule was intraoperatively detected, gross total tumor removal was attempted in a piecemeal fashion. Then, the medial wall of the cavernous sinus or the surface of the pituitary gland, which was in direct contact with the tumor, is additionally removed. We call these techniques supratotal resection technique. Here, I show our practical method of the medial wall removal. And this is a schema of the ceratosca after the selective adenomectomy. Before we do the medial wall removal, the patient's upper body should be raised about 25 degrees to reduce the venous bleeding from the cavernous sinus. In addition, an angled endoscope is used, is suitable for medial wall removal because it can offer an entire view of the medial wall of the cavernous sinus, and it can reduce the blind manipulation. First, we try to dissect the medial wall of the cavernous sinus was dissected from the anterior wall of the cavernous sinus at the inferior edge of the medial wall, here. In this situation, we use the blunt tipped dissector to prevent the unexpected ICA injury. The medial wall of the cavernous sinus was dissected upward from the anterior wall of the cavernous sinus like this. Then, the inferior ceradura is continuously dissected between the inner and the outer layer. After the complete detachment of the medial wall of the cavernous sinus, the venous bleeding from the cavernous sinus is increased, so the transient hemostasis should be achieved to reduce the intraoperative blood loss. After the complete hemostasis from the cavernous sinus, the medial wall of the cavernous sinus is sharply disconnected from the continuous dura mater like this, and it was removed. And this is an operative video showing our practical method of medial wall removal. This is after the selective adenomectomy, and this is the ICA, and this is the medial wall of the cavernous sinus. First, the medial wall of the cavernous sinus was dissected from the anterior wall of the cavernous sinus from the inferior edge of the medial wall. And the ICA was exposed. Then the inferior ceradura was dissected between the inner and outer layer, like this. After the complete detachment of the medial wall of the cavernous sinus, the venous bleeding from the cavernous sinus is increased, so the transient hemostasis was achieved with a hemostatic agent, like this. After the complete hemostasis from the cavernous sinus, the medial wall of the cavernous sinus was sharply dissected from the continuous dura mater by using the surgical scissors like this, and it was removed. And this is the upper part of the medial wall of the cavernous sinus. It was also dissected from the surrounding normal tissue, like this. And it was also sharply disconnected from the diaphragm macerae, and it was removed. After the complete removal of the medial wall of the cavernous sinus, the venous bleeding from the cavernous sinus was stopped with a hemostatic agent with fibrin glue to make a new medial wall of the cavernous sinus. And this is the other supratotal resection technique, the resection of the pituitary gland. After the tumor removal, a sharp incision is made at the anterior edge of the pituitary gland. Then the surface of the pituitary gland was circumferentially peeled off like this, and it was removed. We believe that the surface of the pituitary gland should be peeled off as thin as possible, the thickness less than 1 millimeter, to minimize the impact on postoperative pituitary function. And we never resect the posterior pituitary gland to prevent the postoperative DI. And this is an operative video showing our practical method of the resection of the pituitary gland. This is the operative view after the selective adenectomy, and this is a pituitary gland. And the surface of the pituitary gland was peeled off like this, circumferentially, and the tumor bed was totally removed like this. And after the resection of the pituitary gland, the medial wall of the cavernous sinus was exposed, and the majority of the pituitary gland is preserved. In this study, we retrospectively reviewed the data of 27 patients who underwent transvenosus surgery for functional pituitary adenomas. The clinical, endocrinological, and pathological outcomes were evaluated. And this is patient demographics is shown here, and most frequent preoperative diagnosis was acromegaly. It accounts about 60% of patients, and the second one was Cushing's disease, which accounted about 20% of patients. Almost all cases were primary case, and mean maximum tumor diameter was about 14 millimeters. With regard to the surgical procedures performed, the complete extracapsular tumor resection could be achieved in only 4 patients. And supratotal resection technique was used in the remaining 23 patients. Early biochemical remission by surgery alone was achieved in 96% of patients, and it was excellent outcomes. Unfortunately, only 1 patient showed endocrinological relapse during the mean follow-up period of the 12 months. The surgical outcomes were also evaluated for each surgical procedure, and this is the outcomes of 17 cases with medial wall removal. The mean intraoperative blood loss was 175 milliliters, and no patient showed required blood transfusion. Unfortunately, only 1 patient showed postoperative transient oculomotor palsy, but it was resolved in a week. 16 cases underwent pathological examinations, and it was surprising that the tumor invasion to the medial wall was pathologically detected in more than 60% of patients, as shown. On the other hand, resection of the pituitary gland was also performed in 17 cases. The greatest concern in performing resection of the pituitary gland is its impact on postoperative pituitary function, but no patients showed postoperative anterior pituitary dysfunction. 2 patients showed postoperative transient DI, but no patient showed permanent DI. 16 cases underwent pathological examinations, and tumor cells were detected in the adjacent pituitary in half of patients examined, as shown. The significance of supratotal resection technique has been demonstrated in literature, as shown. And pathological significance of supratotal resection technique was also demonstrated in the current study, because the tumor cells were often detected in the surrounding normal tissues in functional pituitary adenomas without a well-defined pseudocapsule. So we believe that the supratotal resection is an effective surgical technique for functional pituitary adenomas to achieve complete tumor removal. In conclusion, the supratotal resection can lead to complete tumor removal with minimal postoperative morbidities in patients with functional pituitary adenomas in whom complete extracapsular resection cannot be achieved. Although further outcome data are needed to justify the proposed technique, supratotal resection is an effective surgical technique to achieve optimal endocrinological outcomes. Thank you. Спасибо. When
Usually a lot of bleeding
yeah.
from cavernous sinus. How you prevent?
How to prevent?
The stopped bleeding, for example, again.
Yeah. First, the patient body should be raised about 25 degrees, and venous breathing is decreased, and we patch the sagittal sagittal seat, and fibrin glue to patch to make the new medial wall of the cavernous sinus.
You not injected fibrin glue inside of the cavernous sinus?
No, we don't.
Never. Only patch.
Only patch. Because to prevent the postoperative oculomotor palsy.
Okay.
Спасибо за ваш доклад. Хотелось бы узнать, вот контроль гормонов, это гормонально активные же аденомы гипофиза, вот контроль гормонов вы делаете интраоперационно или на следующий день после операции? Спасибо.
We check the pituitary hormone at the next day postoperatively and 1 week after. And we check the hormone level twice a year at outpatient.
In terms of the bleeding from the cavernous sinus, Prof. Sufyan asked for how to control it, and I think packing is a good technique. I don't know whether you use something called a flow seal or Surgiflow. It's like a thrombin powder mixed with the gelatin, which is commonly used in other places. It's called a flow seal. Flow seal, do you have it in Japan?
Yeah.
So I thought that is a good substance to control bleeding if you can't stop it otherwise.
На русском можно? Можно вопрос?
I think the flow seal is not good for the hemostasis for the cavernous sinus because of the thrombosis problem. Yeah, thrombosis come from the cavernous sinus to the yeah. So, and I think it's not allowed by the not allowed. I think you should stop it.
Can I ask some question? Вы используете радиотерапию после хирургического вмешательства, если не удается выполнить тотальное удаление?
We usually don't use the radiation therapy because the functional adenomas is usually effective to medical therapy. So we first do the medical therapy, and if it does not work, it may be radiotherapy is performed.
Вопросов больше нет? Thank you. Thank you very much.
Thank you.
Следующий докладчик у нас Казухико Куразими. Поздние послеоперационные проявления гипонатриемии после эндоскопических трансферендальных операций при аденоме гипофизе. Отделение нейрохирургии, университет Окаяма, Япония.
Okay, thank you very much for giving me the opportunity to present my data. Today, I would like to talk a lot of things. So, this is my topics today. I have two talks. First one is I'd like to introduction and endoscopic transplant surgery, and this is a complication of this TSS. So first, I'd like to introduce myself. Human here, and so this is Japanese, but here is Japan. So then, this is the Japan. Tokyo is the center of Japan. Then Okayama is here, west side, next to Hiroshima, next to Osaka. This is my university. This is my Okayama University, and this is my website. There are a lot of departments, and this is the neurological department, surgery department. So not so many, but we have approximately 550 surgical cases per year, brain tumor, vascular disease, epilepsy, and Parkinson's disease, and so on. So I'm doing mostly brain tumor surgery. He's Dr. Date, he's chairman in Okayama University, and this is me, this is Dr. Ono. Yeah, I'm doing job, so okay. And then this is endoscopic surgery like this. And there are several various projects for brain tumor therapy in Okayama University. This is we are using a molecular targeted drugs and oncolytic virus and gene therapy. This is actually in this month we're gonna start this clinical trial. And cadaver study also we made this deep anatomy system. So another thing is we are doing brain tumor surgery using monitoring and intraoperative MRI and PDT and endoscopic and full HD and 4K or 8K system and navigation. So first talk is so we're gonna talk about endoscopic and these systems. And the endoscope is the source mainly. Mainly we are using a full HD system. So our main endoscopic TSS surgery, I will show you the video. This is a cadaver video. So we are doing transceptor approach. So like yesterday's surgery, live surgery. So this is a boma, and taking a boma bone. This is 30 degrees endoscope, and you can see carotid eminence, prominence, and this is the intercavernous. And here is pituitary gland, and this is cutting a dura. Then we can see here is a pituitary gland and stalk, and here is a chiasma. And you can see this is a sphenohypophyseal artery to the optic chiasm. This is the stalk. And you can see here is PCOM, right PCOM and left PCOM. And this is the basilar top and the PCA. Then I cut this, here's the mammary body to the third ventricle. So we can see this is pineal area, and this is foramen Monroe's. This is our procedure. So one example is I show endoscopic transluminal surgery with full HD system and magnetic navigation system. This is a 46-year-old cases, GH trauma. GH is very high, and here is this is a tumor, and here is normal pituitary gland. Yeah, usually we are using magnetic navigation system, electromagnetic navigation system. So removing the boma bone and cutting dura. We are cutting dura like a H shape. So firstly, I'm taking a tumor for biopsy. Then I'll find capsula for this tumor. Then I'm detecting the line between the tumor area and the normal area. This is a normal pituitary gland and arachnoid. I can take this tumor, pseudocapsular resection. Here like this. Then hormone is recovered. Even those procedure, but we meet some complications, like this delayed post-operative hyponatremia. So, yeah. Endoscopic TSS has become increasingly more popular for pituitary surgery since researchers discovered that it is a safe procedure and introduced optical electromagnetic navigation and high-definition monitors. Hyponatremia generally occurs in a more delayed fashion than transient diabetes insipidus, with serum sodium levels reaching their nadir or on around the post-operative day 7. Delayed post-operative hyponatremia after TSS is difficult to recognize, and its clinical course is difficult to predict. Several clinical studies have been conducted to identify reliable predictors of DPH, but no consensus on which patients are at the greatest risk of DPH has yet been reached. So we retrospectively reviewed our experience with DSS using endoscopy with a high-definition monitor and an electromagnetic neuronavigation system, focusing on the identification of predictive factors for DPH. Our patient is 107 cases from 2010 to 2016. Study design, we divided the patients into two groups according to their serum sodium concentration on POS 3 to 10, the hyponatremia group and the normonatremia group. Hyponatremia was defined as the serum sodium level of less than 135 milliequivalent per liter as previously reported. We checked the magnetic MRI image, and we also checked the lab data. And post-operative follow-up. On the day of surgery, we managed each patient in the intensive care unit. Water balance was maintained with intravenously administered glucose electrolyte maintenance transfusion solution. And postly, the patients were permitted to drink fluid. Once the patient was diagnosed with hyponatremia post-operatively, weight restrictions were often necessary, beginning at 1,500 ml per day. The limits were allowed to decrease to 1,000 to 1,200 ml per day, depending on the patient's response, and the amount of hydrocortisone was increased accordingly. So this result, the median age is 54 years and 68 females, that is 64%. And among these patients, 25, that is 23%, had developed DPH by POS 3 to 10. After the onset of hyponatremia, the mean length of time until normalization of the sodium concentration was 4 ± 3 days. The nadir sodium level was 128. In the hyponatremia, 139 in the normonatremia group. This is a table, result table, a very small table. So I'll pick up some data. So age is a this is a univariate analysis. There is significant value here, and the number of patients taking ARB and ACE inhibitor. And another thing is non-functioning pituitary adenoma, also significant value we have. PSA also, there is a significant difference. Then next step, we use the multi-regression analysis. Those are performed to further test the predictors detected by the univariate analysis. Then among them, age. This analysis shows that the older age was significantly associated with DPH. These results include the age was the most important variable consistently associated with DPH. To evaluate the sequential changes in the sodium level, we compare the serum sodium levels before and after surgery between the patients and with and without DPH. So we make a graph like this. So this round one is normonatremia, and the triangle is one is hyponatremia. So day 2, the serum sodium levels on post day 2 were significantly lower in the 25 patients. That's very significant. We put those data to the, we make a scatter plot to visualize the relations between age and the sodium level, POD2, and calculate the correlation coefficient. So then H was negatively associated with the sodium levels on port 2. These results suggested that the older ages with DPH already had lower sodium levels on port 2, day 2. Then we make ROC curve, then this showed the cut-off age of 55 years can predict DPH. Then the length of the postoperative hospital stay between the two groups. Then the patients with DPH had 3 days longer hospital stay than the patients without DPH, statistically significant difference. I will discuss the post-TSS hyponatremia has been variously reported to occur 1.8 to 35.0%. In our case, is 23.4% of patients. Those are this is consistent with our studies. For etiology of DPH, 16 of the patients with DPH and SIADH, because these patients were not dehydrated, as evidenced by BUN creatinine ratio of less than 20. But not only SIADH, we are thinking this is also other reasons. So, additionally, the water intake volume and the use of vasopressin are similar in the two groups. Then etiology of DPH seems to be SIADH. Predictive factors of DPH, relationship between older age and DPH. And some reports described 50 or 60 years as a cutoff age for prediction of DPH. Our findings of the predictive factor and the cutoff value are similar to these previous reports. So lower sodium levels are early time points after TSS. So we want to know the water restriction to prevent early lower sodium levels could reduce the risk of DPH, especially for patients who undergo drastic surgery. And DPH in patients of advanced age, and present study of the patients lower sodium levels on port 2. This suggests the importance of intensive care even 2 days after TSS, especially in older patients. In conclusions, we determined the incidence of DPH after endoscopic TSS. More than 55 years use of anti-hypertensive drug and non-functioning pituitary adenoma, normal operative were related to DPH in the univariate analysis. And patients with DPH showed significantly lower sodium levels on day 2, post-operative day 2, and older age was negatively correlated with sodium levels on port 2. Consequently, DPH after TSS was associated with increased post-operative hospital day, and water restriction to prevent early decreases in the sodium level could reduce the risk of DPH. Appropriate treatment should be administered whenever hyponatremia is identified. This is published in this year. So this is the first talks for me. So thank you for attention. Спасибо.
Спасибо, доктор Куразуми, за интересную лекцию. У кого-нибудь есть вопросы?
Спасибо за вашу лекцию. У меня один вопрос. Сколько времени больные получали вазопрессин?
Okay.
сколько времени больные получали вазопрессин, то есть, ну, десмопрессин я имею в виду. И у скольки больных развился уже постоянно несахарный диабет после вашей операции?
Yeah, so usually we are putting the desmopressin around 1 week. Yeah, then those are stopped. Until now, most of cases those are transient, not permanent. Yeah. Any
Еще
questions?
вопросы?
Thank you for this interesting lecture. My question is that whether you, when you mentioned that the age is a risk factor for developing hyponatremia, have you adjusted for the clinical cases? As we know that the risk age is the same risk factor as the clinical itself. So, and if you adjust for, I mean statistical adjustment for the clinical condition between those two patients group, I don't see here in this table. Thank you.
Okay. So I think your question is sorry, I don't understand the question. So maybe we are sorry.
May I repeat the question in other words? So both clinical condition of patients and age are risk factors as you mentioned here. Okay, for both hyponatremia. Have you, but in the statistical analysis in the table presented here, I don't see any adjustment for clinical condition as which may be a co-factor, a co-confounder for age. I mean, purely from statistical point of view. Thank you.
Yeah, thank you. Yeah, so as you suggested, yeah, so we don't have many patients for this study. So next step, we want to adjust the age or background. Yeah, thank you very much.
Thank you for presentation. My question is about how often you use control the level of the natri level of the natri in the blood. How often you control?
Control.
Per day. Per day, maybe how long time?
So we are checking that those blood tests post-operative day 1 to day 3 or 3. Then and if there is natriuria decreasing, we are continue to the day 7. And there is the hyponatremia. We are putting taking salt or, and if that is a very terrible case, we put we make dehydrate then and we put infusion of natrium chloride. Yeah.
Thank you.
Спасибо, доктор Куразоми. Следующую лекцию будет читать доктор Такуичиро Хида на тему использования эндоскопа ICG в эндоназальной хирургии основания черепа.
good morning. Thank you very much for giving me a chance to present my here. My name is Takuichiro Hide. I came from Kitasato University in Kanazawa Prefecture. I introduce Kanazawa. Kanazawa has a very beautiful and sightseeing sites. There are many sightseeing sites. So, Minatomirai has a very beautiful waterfront, and Kamakura has a very old historical temples, and one of the famous daibutsu. And Enoshima, Shonan area is a very beautiful beach. Kanagawa is a neighbor prefecture of Tokyo. Anyway, I start my talk. Today I talk focusing on the ICG endoscope. Previously, I used a 5.8 millimeter endoscope, but now we can use 4 millimeter diameter. So, in presenting situation of endonasal skull base surgery, operation range is extended. In sagittal plane, we can approach the frontal skull base and cribus. In coronal plane, we can approach the middle fossa and posterior fossa. However, there are some problems. In skull base surgery, our handling space is very deep and narrow. So we have to make a large corridor, and we use a single shaft instrument and angled scope. Other problem is in skull base, many important structures. For example, internal carotid artery, sigmoid sinus, nerves, and pituitary. For safe operation, we have to use a higher resolution endoscope. So we can use 4K endoscope and 3D endoscope. Other problem is disorientation. Sometimes some part neural navigation system is help us. However, resolution is not enough for skull base surgery. So from these problems, ICG endoscope assist some part. So by fine real-time imaging, for example, when we use ICG endoscope, we can detect ICA and blood flow of nerves and pituitary body. Previously, we used Karl Stoltz ICG endoscope. Usually, we use operation high definition endoscope. The size is 4 millimeter in diameter, and length is 18 centimeter. However, ICG endoscope is diameter of ICG endoscope is 5.8 millimeter, and length is 19 centimeter. Little bit longer and bigger. So at first we prepare the ICG. ICG is dissolved in 10 millimeter saline and inject the 2.5 millimeter ICG and flush 10 millimeter saline. This is a representative case, so it is difficult to detect the ICA and optical carotidolisis. This blue line, I think this is a midline of the cell. So I try to inject the ICG. We can easily detect ICA and detect the intercavernous sinus. However, pituitary body signal of pituitary body is not so high. After 30 seconds, the signal of pituitary body is increased like this. So ICG fluorescence signals is detected through cellular body, cellular bone, and useful to detect ICA and intercavernous sinus. So in this means, ICG endoscope help us to detect the midline and ICA. This is one of the case of tuberous meningioma. Here we open the planum spheroidale and optic nerve and tuberculum. But when we inject the ICG, we can easily detect ICA and detect the intercavernous sinus here, and abnormal vessels we can detect, and stain is here. So these areas are attachment of the meningioma. So these results, we can detect the attachment of meningioma and blood flow of intercavernous sinus. These results help us to decide where we should cut the dura, or how control the bleeding of intercavernous sinus. After tumor removal, I inject the ICG. We can easily to detect the ACA like this, and signal of the ICG in optic nerve, optic chiasm, and stalk. And also we can detect the blood flow of superior hypophyseal artery like this. From results suggested that this intensity signal predict the visual and pituitary function in the point of blood flow. Next, we try to quantify the ICG signal intensity in internal in ICA, internal cavernous sinus, and pituitary body. Left graph shows time until peak signals. First, we identified ICA signal in ICA and intercavernous sinus. And right graph shows the peak signal intensity. From these results, this graph shows the scheme of the time-dependent change of signal intensity. At first, we can detect the ICA and cavernous sinus, and we can detect the intensity of stalk. But signal peak of signal in optic pituitary is around 30 seconds. This is a 21 female procarcinoma. I inject ICG. We can detect the cavernous sinus intensity, and this is a pituitary. This is a adenoma. So adenoma is a little bit late. Signal is in peak. And open the dura. We de-inject the ICG. Here is a boundary of the normal pituitary and adenoma. So we start to cut the edge boundary of the tumor and normal pituitary and totally remove the tumors. This is a scheme of the time-dependent curve of the ICA, cavernous sinus, and pituitary, and adenoma, like this. Adenoma is not little bit lower signals. And previously, we used a 5.8 millimeter diameter ICG endoscope. However, last year we can start to use ICG endoscope 4 millimeter diameter. So this series, we can use 30 degree and 45 degree ICG endoscope. And by downsizing, we can use irrigation systems like this. So when the lens get dirty, we can flow the saline here, and this saline is wash the lens like this. Usually, downside of the endoscope, the resolution is not so good. Because this is a 4 millimeter diameter endoscope, and this is a 2.7 millimeter diameter endoscope. Image is not so good. However, now we can use ICG endoscope. The resolution is good in white light, and also very good view in ICG endoscope, ICG signals. This is a 51 male tuberculosis meningioma. We inject the ICG, easy to identify the ICA here. And we can detect the intercavernous sinus here. And in this case, it is not so good, but this area is attachment. And this area is a pituitary body. After total removal, we inject the ICG. Superior hypophyseal artery is here. We can detect the signal in internal carotid artery and ACA, and also we can detect the signal superior hypophyseal artery and chiasm and stalk like this. And by downsizing, we can do a continuous manipulation under the white light and ICG. This is a Latoke cleft case. We remove the membrane, and this is the ICG condition. We can use, we can manipulate, and we could not change the endoscope. We can continue to do manipulation in the white light. But the previous ICG endoscope is a 5.8 millimeter diameter, but now 4 millimeter. So downsizing, we can easy to do a manipulation. And by downsizing, we can use irrigation systems. So when the get dirty, here is the ICA, and when the lens is dirty, we can irrigate like this, and continue to do observation. So this is a summary. So when we use ICG endoscope, we can easy to detect ICA like this, and detect attachment of meningioma, and evaluate blood flow of ICA, intercavernous sinus. And after tumor removal, we can evaluate the flow of perforators, small perforators, and optic chiasm in the pituitary stalk. And also detect the boundary of microadenoma. Moreover, when we use a 4 millimeter ICG endoscope, we can use an irrigation system like this, and keep lens clean, and decrease the interference with the scope and the instruments. Moreover, by using an angled scope, observation range was extended. So I conclude that ICG endoscope is very useful for endonasal endoscopic surgery. Thank you very much. Спасибо.
Спасибо за интересную презентацию. Есть вопросы? Если нет вопросов, у нас сейчас будет перерыв на кофе-брейк, и через 20 минут продолжим остальные лекции. Спасибо.
Спасибо. Так.
Thank you. We will start, I think, a few more to come. But I'm having some technical difficulties with the laptop and the PowerPoint. Hopefully, I can show you some of my cases. If not, I have to slightly alter the topic or the talk I prepared for today. I want to talk about some of the technical aspects of treating craniopharyngiomas with extended approach, extended endonasal approach. So when I talk, feel free to interrupt or ask questions. So I'll be very glad to take any comments or questions either during the talk or after the talk. I work in one of the old hospitals in London, which is Charing Cross Hospital, part of this trust called Imperial NHS Trust. I have a team with ENT surgeons and neurosurgeons. So as you have heard before, use binasal approach for these cases, and many of the pituitary tumors are used binasal approach, but in some cases you can always do a uninasal approach. With this extended approach is always a bilateral approach. The two-hand technique, the ENT colleague will be using the same screen I use. The nurse is also looking at the same screen, but this arrangement can vary depending on your room size and the number of monitors you have. For example, the scrub nurse can have another monitor here. If the ENT surgeon is standing on this side, he can have another monitor on the back, the foot end of the patient. Navigation is used for all cases. You don't need it. You don't need to have a navigation for standard pituitary tumor, but these days I use it as a standard practice, for it's easy for the residents to prepare it and request investigations for an operation. But I have to tell you, even though you may have navigation, your best dependable equipment is your own knowledge of anatomy. If you identify the landmarks on the patient, and that will be your best hope, because even the best navigation can have 1 or 2 or even 3 millimeters of inaccuracy. And if you totally depend on the navigation, sometimes it can cause problem. If you are drilling near the carotid, or if you're not sure about some structures, don't totally depend on the navigation. Go for the midline, look at the anatomical landmarks rather than going for the navigation alone. Routinely, all these vessels and the tumors are all reconstructed. It's good to have new instruments and always try out new instruments and maybe devise your own instrument to improve your practice. For example, cauterizing the dura, you need a flat tip with slightly angled tip. And these are some of the new instruments coming up with a very thin shaft. It's not bayonet, that is a disadvantage. But the advantage is that you can rotate it. With a bayonet, you have to rotate your whole hand. Here, you just have to rotate the instrument. One other thing with big cases, like cranios or choromas or big meningiomas, one need to have like a backup, like an interventional radiology backup. If you have it, it's really good. Tell them that you're going to do a big operation. There may be a risk of vascular injury, and the only treatment for a vascular injury, like carotid injury, will be interventional endovascular treatment of the carotid injury. It's not a common thing to happen, but if it happens, it can be a bad day. You'll have a bad day in theater if you get a carotid rupture. For example, this is a patient from Saudi Arabia, came for treatment of olfactory meningioma. And initial approach done by my team and encountered a big bleed from the carotid on the left side. It was packed. The patient was sent to the endovascular room. You can see there are two balloons here. One balloon is here, one balloon is there. That is where the rupture was. You can also see some material, which is the packing material inside the sphenoid sinus. So fortunately, you can see there is good collateral from the ACOM. So these things can happen. And when we went back to operate her again a week later, this is the endoscopic view. You can see the balloon here. You see the hole on the skull base with the balloon projecting at you. So this is one of the sort of always you have to be aware of such a possible life-threatening complication. And knowledge of anatomy, I cannot emphasize enough. It's the only thing that is going to help in theater. It's not your navigation, it's not your assistance, it's not your instruments, your knowledge of anatomy. That's your best bet to avoid complication. And to avoid a complication, you have to always be mindful. You have to keep that complication in your mind. If you are trying to avoid a carotid rupture, if you're trying to avoid rupturing the anterior artery or avoiding risk to the optic nerve, you think about that complication during your operation. So, anatomy of the skull base, the position of the carotids and the paraclival carotids, cavernous carotid, position of the pituitary gland, tuberculum cellar, optic nerves, and the landmarks often we look for, the opticocarotid recess, the medial opticocarotid recess. These are key landmarks. And also you have to know which position you're likely to injure the carotid. Generally, if you're going to injure the carotid, it's very likely at 2 points. One could be the paraclinoid carotid, because the carotids come medially and more superficial. So if you're drilling near it, if you're trying to drill off the medial OCR, then you're likely to injure it. The second portion is the paraclival carotid. When you're drilling the clivus for meningiomas or even for choromas, you have to be careful because they are very close by and we can rupture it. So this is a maxillofacial surgeon in London, came to us in 2015 May, was picked up to have this lesion. He didn't have any visual field deficit at that time. So my colleague who saw him waited. He didn't want to, in this high-functioning ENT surgeon, wanted to see how, this is a craniopharyngioma. He wanted to see how it's going to develop. So we waited a bit, and you can see there is a big solid bit of the tumor here, and with cystic component. There is elevation of the optic chiasm with some distortion, but he was well, so we waited. August 2015 is slightly bigger, started getting peripheral field cuts. So it was time to operate this guy. So I prefer extended procedures for craniopharyngiomas. In all craniopharyngiomas, I believe they should be given a chance for extended procedure, even if you think it is probably not operable. Hope these videos work. I was having... So often these craniopharyngiomas do come off the sides of the cavernous sinus. That's the paraclinoid carotid over there, the supraclinoid component of the carotid. So it comes off laterally, and often you don't get any feeders from the posterior circulation into the tumor for craniopharyngiomas. They're often supplied by branches of the anterior system. So you can always safely dissect it. But the important thing is that when you dissect the capsule of the craniopharyngioma and you're tugging on the tumor, you have to be very aware of some of the small perforators coming from the side. So make sure you're not pulling it blindly so that see that vessel there? So these are the structures you have to be careful. If you just not careful about it and you rupture it, it might retract back into the cavity and then you may not be able to see it even with a 30-degree or 45-degree endoscope. So this talk is mainly to tell you about this sort of possible scenarios of complication you can have. So this is coagulated and divided before you go further. So this is in after the operation, post-op scan with a follow-up scan which shows total excision. Another follow-up in 2016. So you need to have a good bony exposure. Normally for craniopharyngiomas, you don't need to take off the planum because often it's behind the optic chiasm. You can limit your recession to the stellar floor and the tuberculum. Maybe a little bit of planum you can remove, but you don't need to take off planum like you do for a meningioma. And often you start debulking the tumor and drain the cyst. That will give you enough space to dissect around the tumor. And if you have to leave some capsule to protect the optic nerve or some of the perforators, you have to do it. So don't aim for a complete radiological excellent result. You have to satisfy with a fully functioning patient without any deficit. Some cases are difficult ones. So for example, if a young man came as an emergency patient with a big tumor with a large cyst going into the third ventricle causing obstructive hydrocephalus. So this is not an easy one to operate. You can take off the solid bit, but there are tumor on the walls of the third ventricle. The lining is enhancing, so it may be difficult to excise it completely. So here I could not do a total resection. Let's see if this video works. So dissecting off the sides of the intracranial cavity is also, so this is craniopharyngioma which I'm resecting. The last bit is a redo operation. Let's see if I can forward it. So you can see the sides, this stalk here, and have to be careful about this perforator. This is the side. So these vessels and the vessel, the small perforator on the side, have to be careful when you dissect off. You don't want to interrupt the branches of the superior hypophyseal. It's going into the optic chiasm and also traveling onto your pituitary gland. You don't want to interrupt those vessels. So lateral dissection of these tumors should be very careful. You can see the rest of the anatomy there with the anterior complex. And the perforator, you can see the perforator is coming off from the anterior complex back to the chiasm. These vessels should be protected. And this is the best view you can get with endoscope rather than doing a cranial approach for these cases. How about pituitary shock? You know, it's a craniopharyngioma. They often attach to the pituitary stalk and often difficult to preserve. So my policy with these tumors coming from the pituitary stalk is that I try to preserve it possible first time. But second time when they recur from that small remnant, it will be an elective recession of the pituitary stalk leading to permanent DI. But that is something which is consented for and everyone needs to agree. Depending on the patient's age and the rest of the lifespan, you may have to do that. So another young lady who works in a high commission, came with visual loss. So these fibers, these branches, see there is one branch coming onto the pituitary gland, one branch going onto the optic chiasm there. So these branches, even though they may appear to come onto these branches, they may appear to come onto the tumor. Often they are en passant vessels traveling to important structures. Careful about those branches. You often have to gently separate them before you take out the tumor. So it's another young man who I treated twice. This is the second operation for him. First time he had a big craniopharyngium which was resected, had to leave some tumor around the infundibular stalk. This is the infundibular stalk here. The tumor recurred here. It's a big cyst, so that's the stalk. It's all attached to the stalk here. So this time I had to resect the stalk completely. So this is all, the stalk is being divided here, and then it will be excised totally this time. So that second operation with the resection of the tumor in the pituitary stalk cured him. He never had to have any radiotherapy following it. Normally, we tend to consider upfront radiotherapy for some of the craniopharyngiomas if you leave behind it. But depending on the excision, you can decide whether to wait and watch or to consider upfront radiotherapy. So it's being removed. So this is one of the top bankers in London who came with another craniopharyngioma in 2013. You can see it's extending to the floor of the third ventricle. So extension to the floor of the third ventricle is not a big issue. Often the floor of the third ventricle is very chaotic and damaged and thinned out by the tumor. So you can always resect it. Often when it goes onto the side of the lateral walls of the third ventricle, it is an issue. So it comes off the side walls. You can see it's a fairly solid tumor, the branches of the basilar artery here. You can see the optic chiasm and the third ventricle here. So on the side, it's very calcareous. You can see the third is already open, and it comes off from the side without much. You can see it's already open there, anterior commissure there, and it comes off easily. So it's a slightly different tumor. It's not attached to the side walls of the third ventricle. So this is the post-op scan and follow-up. Still, often you see a thickened tissue here. It's the nasal flap we use. So it's important for radiologists to know when they see the flap after the scan, after the operation, they think that there could be like a foraminangioma. If you're telling them that you're doing a post-op scan, they often think this is a residual tumor or recurrent tumor. You have to tell them that we have used a flap which they're going to see as a thickened tissue. Send the young guy with a big cyst with a small nodule. Initially, someone drained it to the nose. Then I had to go and remove that nodule. I didn't think the rest of the cyst was tumor tissue, so just remove the nodule endoscopically and put a fat graft. Again, normally I don't use fat graft for these cases, but this case I used, but then he got infected. So this is a fat graft with some infection in it, so that had to be removed. That's removed, and then 2015, the tumor started to get bigger. So you can see there is another tiny nodule, and perhaps a recurrence. And in 2016, it got bigger with another nodule. So I had to do further endoscopic approach to remove that tumor endoscopically. But still, it came back. So these tumors can come back, irrespective of. So this is he then was sent for radiotherapy, and during radiotherapy, the oncologist was panicking because of cyst recurrence and losing vision. So I had to take him to theater again, this time through the supraorbital approach to drain the cyst and resect it. So then he remained well after the radiotherapy. And one other thing which you have to be careful is the adhesion to the optic nerve, which is also, so these tumors are attached to the optic nerve sometimes, and also to the corner between the infundibular stalk and the optic chiasm. You often have to leave some remnant to protect it. So another young man, I had to operate him for CS oblique at least 4 times, this guy. Okay, I think that's the last slide. See if it's working, and then go for the next one. So optic chiasm is another problem. This is a cyst wall coming off the optic chiasm. I had to leave some capsule on the optic chiasm on the left side. And but that was a very thin capsule. I didn't think it was going to come back, but just before I came here, oncologist sent me an email saying that the tumor has come back. So I'll be planning to take him back to theater again. So these tumors, if you leave some remnant, it can come back, but it's better than causing damage to the optic chiasm. That is it for some of the technical nuances for the craniopharyngiomas. think I've done. This is the last slide. Thank you.
Спасибо за интересную презентацию. У кого-нибудь есть вопросы?
Please.
Thank you for beautiful surgery and presentation. And my question is, the case of retroinfandibular type, the intrasubventricular type of craniopharyngioma, don't you consider the draining of dorsum sellae to get the corridor to the tumor?
Yes.
Especially in the case the chiasm is the position of the chiasm is very low.
Yes.
There's a very little space.
Yeah.
So we need to get more corridor. So in such a case, we consider the drilling of a dorsum sellae. So how do you manage
those cases are slightly difficult than the standard craniopharyngiomas you see. Tumors mostly retroinfundibular are behind the stalk and the pituitary gland. That will require taking off the whole of the cellular floor and then lifting off the pituitary gland and push it more anteriorly. So you have to go behind the pituitary gland and drill off the dorsum cellular. I totally agree with you that you have to take off the dorsum cellular to get to it.
Okay. Thank you.
There.
Thank you very much. Ramesh, very good talk and very good videos. I would like to ask your experience of how do you handle the closure of the defect that is created after the removal of the
Sorry,
the
how do you handle
defect.
what the defect?
The defect.
Defect.
That is. The other one is, what is your incidence of CSF leak in these patients?
So I'll start with the second question first. The CSF leak, so it's a matter of learning experience with these sort of conditions. Early in your career, the CSF leak is really high, about 25%. But later on, it tends to come down with, you are trialing with the different techniques. Initially, I was using fat and facial elastograph and lumbar drain and Foley's balloon, all techniques. And later on, then you try to find out which is better. And then I stopped using Foley's catheter for the last 1 year. I used to put Foley's catheter balloon to support the repair always. But I had one case, the last case I showed, who had a CSF leak repair at least 4 times. What happened was that the balloon, I didn't know what was causing the problem. When we went back in, the entire flap was completely necrosed. So it was all dead. And looking back at the immediate post-operative MRI scan, I thought the balloon was blocking the pedicle. It was pushing onto the pedicle, thereby making it avascular. That was my hypothesis. So I stopped using Foley's balloon for that condition, and I only use the repair is often an inlaid Duragen. I think you mentioned it yesterday, inlaid Duragen. Then I put an onlay Duragen. On top of that, there will be a flap, nasoseptal flap. Then edges of the nasoseptal flap are generally covered with Surgicel. This is to avoid the glue getting under the flap. You don't want any artificial substance between your flap and the skull base. So that Surgicel lined around the edges, and after that we use a glue called Duraseal. There are many glues are available, so we use Duraseal, and on top of that we use like a sponge-stand layer. That is to avoid to displacement of this the Duraseal when you remove your packing or your balloon, so you don't want to come off. So you put a sponge-stand layer over it. And always used to put a lumbar drain. I still use lumbar drain for more cases. But some cases, I don't have to use it, but try to use it. Does that answer your question?
Yeah, I think that's very correct. And I think those who would like to undertake extended radical approach for the anterior cranial fossa, they must understand that, CSF leak is the complication of this procedure. And we need to look into every aspect of that, other than, of course, as you have very rightly mentioned, how to remove the tumor and to be careful with the stalk. But I think the over-patting is also something which is not recommended, and we need to be very gentle. As I said yesterday, that I have stopped, putting in even the packs, and I think on top of everything, inlay, outlay, and fat. One more thing that I would like to, point out here is that never put the fibrin glue on top of the Surgicel. Put it on the fat graft, because then it holds very good. I thank you very much.
Just one point, Tariq, I would like to mention. You mentioned about overpacking. I just wanted to tell you about one complication an ENT colleague of mine had. He did a biopsy from a skull-based tumor near the pituitary gland. It's possibly a secondary deposit from a breast cancer. He did it himself, and he had a CSF leak. He used packing with Spongestan, and that is his usual practice to repair CSF leak. He pushed in a lot of Spongestan inside that defect, and then that night patient lost the eyesight, and then I had to take the patient back to theater to remove all this Spongestan. As you know, the Spongestan will swell up with the fluid, and they act like a mass effect. Unfortunately, the patient lost eyesight, but it was an advanced stage breast cancer, and she died 6 months later. But the family ended up suing the hospital. But that's something which I don't try to do it anymore. And even if you pack, you just have to use minimal or moderate amount of something inside the cellar, but not overpacking.
The other point that I would like to make here is the detection of the CSF once you have done all these surgery, and also in patients who have got CSF fistula, that I use fluorescein dye, and I think it is injected 1 hour before surgery. So by the time you are there, or 45 minutes before that, so you can easily detect from where the CSF is coming.
So what dye? Fluorescein.
The fluorescein dye.
Yeah.
So I think for the young neurosurgeons, it is important that we must be able to properly detect from where the CSF is coming. And as I think Ramesh has said, do not put, the material like Spongestan or Surgicel, I think, without putting a graft and fibrin glue.
Thank you. Any other questions? Yeah, go on. Oh, let me put this.
Спасибо за хорошую лекцию. У меня один вопрос. Были ли у вас случаи, когда вы пересекали стебель гипофиза для радикального удаления кранифарингеала? Или вы всегда стараетесь сохранить стебель и оставить какую-то часть опухоли? Спасибо.
Thank you. I have mentioned that in my talk. I will try to preserve the stock in all cases, even if I have to leave some tumor behind on the stock. Some of these craniopharyngiomas, you don't know the kind of recurrence they're going to get and their growth pattern. So it's safer to leave the stock undamaged if you can. But the case I showed you where I had to go back in, the tumor did recur in a young man. And the only way to cure him from a craniopharyngioma, which as you know are difficult tumors to treat in some cases, is to remove the tumor completely. So second time I had to go back in with a pre-operative planning for a total stock resection. So it's not a common thing to happen, but occasionally you may have to do it. That's clear? Okay.
Еще вопросы? Если нет вопросов, в следующей лекции будет читать доктор Казухика Куразоми на тему трансминальная хирургия с использованием PhD эндоскопов.
Okay, again. So next, this talk is about transcranial surgery by using Full HD, 4K, 8K endoscope. So I'm going to start. So this part. These topics are these new systems, and I will show exoscope also, and monitoring and EM navigation, and I will show a new navigation system. First one, endoscopic procedures have recently been increasingly performed in neurosurgical field. We introduced a full high-definition HD system in 2013 at our hospital. To improve the accuracy and safety of our endoscopic procedures, we are currently trialing 4K and 8K systems. So here we present our experience of endoscopic surgery for the transcranial approach. We retrospectively identified 131 patients, 50 males, 81 females, mean age 55 years, from 10-year-olds and to 55, who experienced surgery for several lesions with endoscopic procedures at our university hospital. We used Full HD endoscope system storage and organic electroluminescence monitor for 102 cases, 4K systems. Now it's 15 cases. This is increasing now. So, and 8K system, those are Kairos for 4 cases. And between stores, this is also increasing the number exoscope. So this is our system, raised endoscope straws. We are fixing this with a uniarm, and we are using organic electroluminescence monitor, Sony. And usually I'm using station S7 electromagnetic systems. This is a patient tracker, this is a seal type, and this one is a malleable suction probe. 142 patients who underwent surgery for several lesions, mainly pituitary adenoma, and the cranioharyngioma is the number is increasing. I will show us several cases. This is the pituitary adenoma into the third ventricle area. A very tough case for me. So I'm using a navigation system. So I'm deciding the during sterile lesion and cutting a dura. Here is the intercavernous. Here is normal pituitary gland, and the very bleeding in here. After cutting intercavernous, the tumor is coming out. So it's hard to take tumor. So then I cut normal pituitary partially. Then I'm aspirating a tumor, so I can detect the area in the aspirating now with the navigation system. So we can that is canal, and then this is a 30-degree endoscope to the downward. I saw that. Then this is the mammillary body, and here is the basilar top area, and this is Monroe foramen, and this is so this is to the fourth ventricle. So here I could remove totally. So other case, this is a craniopharyngioma. This was a tough case, 25 years of a male. Here is the tumor. I show the video. I'm cutting a dura, then the intercavernous sinus, and here is normal pituitary gland. This is there are many vessels in front of the tumor, and I couldn't come into the go into the tumor area. Then I found the area of a cyst with the navigation system. I cut here then tumor volume was getting down. Then you can see like here is cyst with the navigation system. The aspirate here during this procedure, I'm preserving those small vessels. Then we could go the bottom of the tumor, and there's no vascular area. Then I go into the tumor area and do using CUSA, then get down the volume of tumor. And this is chiasm. And taking a tumor, then using CUSA. This is not dangerous, very safety. I'm using CUSA on the front side. Then this is the chiasm. And we are using draw wave and or fascia and the bone for fixing here. So I totally remove this tumor. So for 4K, those are full HD system. Even full HD system, we can do that. But 4K system is very clear vision. 14 cases and those pituitary adenoma and craniopharyngioma and ratoke. The 4K is around 4,000 pixels, and this is 2,000 pixels. Ultra high definition and wider color gamut and magnified visualization. This is Sony Olympus system. This is 37 inches monitor and 55 inches monitor. And this is a camera head for 4K. I'm doing surgery like this. So usually I'm watching this 55 inches monitor, very clear and high quality. I'll show the one case. This is 4K data, so I cannot show the full, but I'll show this one. This is craniopharyngioma case. So intercavernous, I'm cutting here. And the advantage is that you can see the very small vessel clearly. So like here, so very clearly, superficial artery and optic chiasm. I cutting the like a stroke area next beside the stroke area. So it is easy to detect small vessels. And if we use small diameter endoscope, that is we can see that more clear with 4K system in the third ventricle area also. So this is the older age person, so then during surgery we stop removal. Yeah, we get down the volume. So electric zoom allows for the scope to be moved from the operation field. So this is one time. So this is bone by bone. Here is the distance, operative distance. So then if we use magnification like 2 times, so we can get have a distance like double. Then it means in order to avoid mist and smoke and to reduce sword fighting of hand instruments. Then next one is 8K. 8K is 4K is 4,000 and 2,000. This is 8,000 and 4,000. So and then this is the monitor. This is a 17 inches monitor. This is a huge monitor. And the camera head is not so small, but this is like this. So yeah, I'll show the video intraoperative area. So like this, we are preparing for this 8K system. I'm using Uniarm to fixing this 8K system. So difference between 4K and 8K is high definition is clearness is we cannot understand for human, but 3D image is very good, better in your 8K system. Like a 3D, you can see that. So because very color is vivid and clear, so line is clear, then we can know that we can think this as a 3D. So next one is the endoscope in Japan. So worldwide also, I think now so endoscope is now developing, and many institutions are having and developing those systems. Bitom salts and OVI for Olympus, and Kinevol size, and Vision Sense for DS3. Now we bought this Bitom 3D system like this. So we are now there are many so several cases which are done before. One case is very interesting. I showed an interesting case. Medulloblastoma 7-year-old male. So this is tumor in the fourth ventricle, like this. So this is OR. So here is a monitor. This is a full HD system, and Uniarm. There is a Bitom head here. This is a 90-degree Bitom. So then, for backup, we are preparing this microscope. So I'll show you a video. So wearing 3D glass, like a Terminator, kidding. Then, so this is a resident doing that there. And just watching this monitor. This position is a little bit higher, so now it's getting lower. But usually, fourth ventricle tumor it is hard to do surgery, not good position for surgeon. But there is a very comfortable for a surgeon to do a surgery, dissection or cutting and coagulation. But navigation is we cannot use the boundary navigation. If we need to navigate, we use a microscope in that time. But pointing navigation, we can do that. So I'll show that surgery. This is the top and bottom. This is the Bitom view. Cutting dura, this is the center. This is the infant case. There is obstetric sinus very bad, very a lot of obstetric sinus flow. And cutting here, middle, and cutting left side, but bleeding here. We use a fluoroscope. Fortunately, this tumor is coming out surface a little bit. Then we cut here like 1 centimeter. Very less invasive taking tumor here. Using CUSA, and then here is cerebral area. It is easy to go to the lateral side. This is the fourth floor. Then for confirmation, we use microscope, then NIM, this is the facial follicles. Yeah, using easy to use this Vitom system. So the tumor totally removed here. So next topic is monitoring and EM navigation. Usually I'm using EM navigation and recently VP monitoring for a huge big tumor for the pituitary adenoma. And this magnetic EM navigation system, the company said we should use this 15 centimeter. But in that case, we cannot use a VP monitoring because of a noise. So we found this is a distance. If I have more distance like 20 to 25 centimeter, like here, so we can use simultaneously monitoring and EM navigation system. So if that is a narrow distance, there's a huge noise here. But if we have 25 centimeter, we can detect VP monitoring. So, for example, this is a tumor, pituitary adenoma. So, hemianopsia, we could take a tumor. There's a VP, so not so high, but after operation, there's a wave here. So last thing is I'll show EM navigations. Yeah. So there's a new one, stereo station S8 for Medtronic and Brain Lab Kick EM. Both EM navigation. So S8 is different from S7 because this tracking volume is getting higher, so wider. And we can use a flat emitter in the S8. And we can have a switch off for the navigation emitter. So we can switch off, we can use monitoring. So these new stuff. But sometimes we can use navigation and monitoring this distance. I'll show one example. S7 chordoma case. There's a huge tumor into the brainstem. So this is a S8 system. You can see this is bone area, so now drilling. This is a reoperation patient. So then drillings, and we can know that vessel structure like this 3D system. So then taking a tumor. This is a recurrence, so then just taking a tumor inside the tumor. So taking a tumor, just accurating. So advantage of S8, so you can see that border line with 3D image. Then we can know that there is a border here. And take a tumor. Then we use a fluorescein. What? Then down. And totally removed here. And next one is Brain Lab system, Kick EM. This is also very easy. Both registration is very easy. This is pituitary adenoma, so very similar to the H system. So this is emitter of EM navigation, and this is like a patient track here, and it is easy to do registration. This is pituitary adenoma here, so I show the video. Advantage is for this EM brain lab navigation is we can use your own instruments. So you can register your own instrument. So there's a diaphragm taking a tumor here. And upper area also. So totally we could remove here. Now, yeah, that's all. So for I talked 4 things, and I talked all of them. Thank you very much. Спасибо.
Спасибо за презентацию.
Very much.
Есть вопросы? Если нет вопросов, перейдем к следующей лекции. Спасибо, доктор Куразоми. Следующую лекцию прочитает доктор Казухита Такеучи. Эндоскопическая хирургия супра- и интрацеллярных образований.
Is it okay? Okay. Okay. Hello everyone. Today's my topic is endoscopic transfemoral surgery for the supra and intracellular regions. Endoscopic transfemoral surgery become first-line treatment for the intra and supracellular regions. The adaptation of TSS is spreading to the giant pituitary adenomas and other supracellular regions. Today's outline is here. First one is TSS or pituitary adenoma. Adenoma can be removed using various surgical techniques. This tumor is relatively soft and suckable, so we can remove the tumor with suction, internal decompression technique. Well, of course, it's fine. We have to use 30 or 70 degrees to confirm the no residual tumor on the corner, like that. But so it's very nice technique, I think. And the extracapsular dissection technique is effective for the functioning pituitary adenomas, as Professor Nagata said. This technique is also used for giant adenomas and adenoma with supracellular extension. In this patient, patient had a relatively hard component in the upper side. After that patient, we leave this component alone. After the surgery, the patient had a hematoma formation like that, and visual acuity is deteriorated. To avoid this kind of complication, we have to remove the total adenoma. In this 47-year-old female, okay, with visual disturbance, relatively large adenomas, we expose the pituitary capsule and identify the normal pituitary gland here, and dissect normal pituitary gland from the tumor, like that. This is the pituitary capsule. Of course, some decompression is required, like that. But after the decompression, we can dissect the tumor capsule from the normal pituitary gland easily, like that. Much easier. After that, we dissecting the tumor from this part, like this, and totally removed. gross total removal was achieved. But I think there is some technique is required for this technique. As you can see, how do you feel about this case? I think you think this case is easy. But note, this case is, actually this case is not so difficult case, but sometimes it's difficult. Because in the T2 weighted image, the intensity is low, so it indicates hard or fibrous tumor. And normal pituitary gland is surrounding the pituitary adenoma, like that. So you have to identify the normal pituitary gland first. After the adequate decompression, we dissect the tumor from the dura, like that. And look at this point. This is a normal pituitary gland. The tumor. And this is a normal pituitary gland. So this is a pituitary capsule, not a tumor capsule. If you dissect this plane, you will remove the total normal pituitary gland. So we have to cut this point, like that. And then find the tumor capsule and dissect it. As you can see, this is a normal pituitary gland, and the tumor capsule is here. And this is a complication of the extracapsular dissection. Little bit old video, but this is a very impressive case. We dissect the tumor capsule from the arachnoid, like that. Little bit strongly pulled, I think. It's not so difficult to dissect, but look at this. The arachnoid membrane become reddish, like that. I didn't notice this phenomenon at this point. But like this, hemorrhage occurred, like that. And we cut arachnoid, like that. And see the suprasellar area. Like that. At this point, we can identify the hemorrhage point, but so we irrigate, washing, and finally stop the bleeding. And open the suprasellar area. There's no hemorrhage. Unfortunately, we could achieve the hemostasis simultaneously. After the surgery, I'm very fortunate. The hemorrhage is not so severe, and the patient is doing well. But this can be a fatal complication. So we should avoid poor surgery. Extracapsular dissection technique is useful for the removal of giant adenomas and adenoma with the suprasellar extension. Detecting the normal pituitary gland is essential, and gentle blunt dissection is a key technique. And don't pull the tumor capsule without countertraction. The next is craniopharyngeal cases. Extended TSS is now widely used for the removal of craniopharyngeal cases. Superior hypophyseal artery should be preserved to protect the visual disturbance and pituitary function. As you can see, this is SHA, superior hypophyseal artery, and that supplies the optic nerve. This one is optic branch. And there is a descending branch. This artery is supplying the pituitary and diaphragm sometimes. And the most important artery is here for pituitary function. This is the infundibular branch. I think you are very careful to the optic branch, but this artery is also important for the postoperative pituitary function. This 47-year-old female with visual disturbance case, the tumor is very small, so we choose observation. But after 1 year, the tumor enlarged a little bit, but the patient didn't have any pituitary dysfunction, and but the visual acuity deteriorated, so we performed the removal. Extended transfemoral surgery was performed, and here is the tumor. We want to preserve the all pituitary function, so we preserve these arteries around here. Tumor was dissected like that. We preserve the arteries and the pituitary socket as well. Look at this. This is the pituitary capsule. So, tumor capsule. So we dissect it. Now I'm using 30-degree endoscope. We can see the third ventricle like that. And the gross total removal was achieved. And the patient doesn't have any pituitary disturbance. This research is about infundibular branch preservation. The inclusion criteria is here, craniopharyngioma case, and no preoperative pituitary disturbance case, and stroke preservation was achieved during the surgery. Only 12 cases was included in this study. But this one is a very busy slide, so look at this list. If the SHA, bilateral SHA infundibular branch was preserved, in focus, the anterior pituitary function was also preserved. And only one case was experienced DI. No SHA infundibular branch was preserved. There is no preservation of the anterior pituitary function. So even the stroke was preserved, the pituitary function is not always preserved. So SHA preservation is important for the postoperative pituitary function. I adapt this thought to the third ventricular tumor. This one is a relatively large tumor, 80-year-old boy. To protect the pituitary function, we removed the posterior crinoid and dosum sera as well. This is the posterior crinoid. This is sera, and the crevice was already drilled out. And posterior crinoid was removed like that to make a wider corridor. We can push down the pituitary gland. And now we can see the SHA here, and the stroke is here, optic nerve is here, and the pituitary gland is here. We preserve this artery. This is the infundibular branch, so we have to preserve it. But still very narrow corridor, so we cut the pituitary gland, 1/3 of pituitary gland here. We can get a wider corridor. Now we insert an endoscope to the supracell area, and we can see the tumor here. This is not a tumor. This is a tuberculum and pituitary fibers, stalk fibers. So we dissect the tumor from this membrane, like that. Now we are dissecting tumor from the hypothalamus. Like that. Here is the mammillary body. And now we are dissecting tumor from the upper part. This is the anterior commissure. Fortunately, generally the craniopharyngioma is not so strongly adhered to this compartment, but in this case, adhesion was seen, so we dissect it. And after the dissection, we remove the tumor like that. Pituitary gland and the stalk and the artery was preserved, and all tumor is gone. Gross total removal achieved. Unfortunately, he had partial DI and partial pituitary disturbance, but this case is last month's case, so I think it will recover. Preserving SHA is important for postoperative visual acuity and pituitary function. Adequate surgical corridor is essential to prevent postoperative complications, including pituitary function. The next one is the tuberculum meningioma case. Tuberculum meningioma can be removed with extended TSS, but there are some disadvantages in this surgery compared with craniotomy. That is a narrow surgical corridor and lack of adequate surgical tools and CSF rig. I'll show you some techniques. First one is skull-base opening. To make a good corridor, foreign structure should be removed. Bony depth inside the sternum sinus should be removed totally. Of course, the tuberculum sera should be removed until the medial OCR was exposed. This point is quite important to expose the ICA and optic nerves. And the prominent sphenoid array should be removed. And sometimes, in some cases, we have to remove the optic canal because this tumor is generally embedded into the optic canal. So after the removal of these structures, we can get this shape of craniectomy, like a chef's hat. I show you one case. The next is removal of tumor. A 60-year-old female, left visual disturbance case. In this case, we perform the chef's hat opening, like that. The optic canal is here, drilled out. Cut the dura. This is a tumor. Tumor was dissected from the surrounding brain. This is the optic nerve. Fortunately, this tumor is not so strongly adhered to the surrounding brain. And debulking was performed. Fortunately, there is no adhesion to the ICA and some other structures. So we rotate and pull up the tumor and debulking, and cut and removed. After the removal of the most part of the tumor, we confirm the optic canal here. This now I'm using the 70-degree endoscope. This kind of tumor embedding to the optic canal, so we have to remove at this point. After the removal of the tumor, you can see the optic nerve very well, and you can see the stalk here. Like that. Gross total removal was achieved. And in this surgery, the problem is lack of debulking tools. Of course, you can use the QSA and microdebrider, but I dislike that kind of things with some problem. I use this kind of debugging tools. This one is suction Kelson punch. Look at this video. This is a fibrous tumor, but we can suck the fibrous area and cut the fibrous tumor like that. I think it's very safe and effective tool for this kind of tumor. The next one is the closing dura. I use the fascia patchwork for the closing the dura. This is a bone and this is dura, and so this is a bone and dura defect. It's a sagittal view. And we put the fascia here as the inlay graft and suture the dura and put the fat graft and then compress the fat graft to the cranial side with absorbable plate, like that. Look at this video. I sutured the dura like that, and the fascia graft was inserted as the inlay graft, and sutured the dura like that, continuously sutured like this. We sutured this side, and after that we sutured the opposite side, like that. Sometimes I can't catch a needle. And tightly tied. We confirmed the no CSF leak with the valsalva maneuver at this point. But we put the fat graft and compressed with the absorbable plate like that. I think this is a quite robust technique. Adequate opening of the skull base is important, and developing the tumor make it easy to detect the tumor from the surrounding brain, and the fascial patchwork technique is useful for preventing the postoperative CSF leakage. Thank you very much.
Thank you very much. I think a very good presentation. I would like to ask you the same question. After, I don't stitch the graft there, but you have been, and I've seen many others who stitch the graft. So is there any significant difference in the CSF leak in your cases if you stitch the graft?
Of course, in the meningioma case or the chordoma case that was embedded to the dura, in such case we have to remove the dura completely. So the for suturing dura for the suturing is very small and fragile. It's a little bit difficult to suture, but I don't have, I can't suture the dura so far. So,
okay, what is your preference of the size of the tumors, or what will you like to advocate or recommend that we should not go for the endonasal transsphenoidal approach endoscopically for tumor which are large size tumor? Do you have any preference?
So you mean the
Size.
but for meningioma or craniopharyngioma cases? Also, in the meningioma cases, I think the 3 centimeter is a very good indication, less than 3 centimeter. And I think the size is not matter. But I think the lateral limit is the most important thing. If the tumor is extend over the lateral limit of the ICA, it's a little bit difficult to dissect. Precise dissection is quite difficult from the transnasal route. So if the tumor is 3 centimeter or more, 4 centimeter, 5 centimeter, but the tumor is located in the middle, I think it's still a good indication for the transfemoral surgery. And in craniopharyngioma cases, first surgery should be performed from the transfemoral surgery, I think, because tumor is originated from the stalk, the middle of the cranium. We can detach the tumor from the from that stalk. So I think the craniopharyngioma should be performed the TSS first, I think.
Nice talk, excellent videos as usual. I just would like to make one comment to what Derek asked, and one question for you. A comment about the indication or how do you select the approach for example, tuberculum cell meningioma. Extension to the coronal plane is an important factor. How lateral it goes to the optic nerve, and also how laterally it goes towards the carotid artery is a major factor in deciding it. I select cases which limits itself just to the medial aspect of the optic nerve, at least half of the optic nerve. If it crosses half of the optic nerve in the coronal plane, I tend not to select the endoscopic approach. There's one question about the suction Kerrison punch. First time I'm seeing it. Do you ever have used something called a micro debrider? You like it?
Yeah, I sometimes use it, but I have one complication from the hemorrhage from the artery.
Okay.
Because that instrument can be moved with foot switch. Foot switch cannot. We can stop the movement of the microdebrider very smoothly.
Okay.
So I should use this kind of.
Yeah, so it's more control.
Yeah.
Thank you.
Fujita. Do you use Nika? Nico? Yeah, I don't use it because that's not available in Japan because of the commercial problem.
Если вопросов нет, спасибо, доктор Такирович. Следующая лекция будет доктора Рамиша Наира по лечению менингиома основания черепа.
Works. There was some technical issue with the PowerPoint again, so the title of topic is slightly different, but it fits in nicely with the topic we've been discussing so far. How do you select the approach for tuberculum or planum meningiomas, and what are the decision factors, whether you want to go through the head or you want to go through the nose? It's often difficult to decide. There are many factors. This is a lady I treated. She came initially in 2011 with this meningioma. Looks fairly ideal for an endoscopic approach. And she was being watched for some time and was sent finally when the tumor started growing in 2014. So almost 3 years there was no change, but it gradually grew and she wanted to get it out. And as you can see, it is over the planum but spilling onto the olfactory groove there. And the antiacetal artery vessels are far behind. So a few things I look for: the involvement of the antiacetal artery and how much infiltration and the border of the tumor with the brain. So it's an important factor. You can see that especially on T2 weighted pictures where there is an arachnoid plane between the tumor and the brain or the optic nerve. She's got another one which is not doing anything. So this is the scan. Again, grew just before the operation, 2015. So this is the endoscopic approach for this case. The advantage of endoscopic approach for these tumors is that is the posterior ethmoidal artery. You devascularize the tumor as soon as you start the operation, which you cannot really do with the transcranial operation. And also this is the base of the tumor. With these tumors, often you find thickened bone or hyperostosis. It's actually containing tumor cells. And you have to take it off, which lead to a total resection of these tumors. If you do it through the head, often at the end of the operation you have to drill the base, maybe enter the sphenoid sinus to get a good clearance. And the recurrence of these tumors often related to leaving tumor on the skull base. Here the dura is cut all around it. So take off some of the cellular floor and the tuberculum and also the planum around the tumor. So you get a wide margin around the base and you define the edges of the tumor. So this is the advantage of endoscopic approach. You devascularize it. The primary blood supply from the posterior ethmoidal arteries are cauterized. You cut the tumor around the dura, so you detach it, and then you remove that bony base. These are the advantages of endoscopic approach for these sort of tumors. Here you can see the tumor was infiltrating. There was no arachnoid plane here. These vessels, some of the branches of the anterocerebral artery, the tumor is beyond it, it's above it. So, but depending on the tumor consistency, you may be able to remove it without much problem. You can see that's a branch which is draping over the small remnant. And often with a careful dissection, and you can remove that remnant without much difficulty. But the important thing is that you have to follow the same principle as you do for a standard microscopic approach. So she's been followed up, last scan 2018, no recurrence. But this is a nurse. She came with, first manifestation was seizure. So it's not normal for tuberculum cellular meningioma to present with seizure. Often they come with visual loss. Most of them, almost 80% of these patients will have visual loss. They present with visual loss. Some will come with seizures, some will come with some olfactory problems, but mostly visual loss. And you can see hyperostosis here. But here you can see the vessels are incorporated into it, and it will be a difficult one to resect through the endoscopic, but it's still an option. Here also, this is the thing, the question was for Tariq, you asked. So look at the encasement here. This is a coronal section of the optic foramen. Look at the optic nerve here, and you can see the tumor is encroaching onto the optic nerve. But more importantly, it is going lateral to the optic nerve here. And that will be a sort of limiting factor when you go up the nose, and that part of tumor will be left behind. So this one, I selected a supraorbital approach. So again, it's a standard approach for such a tumor. The subfrontal approach, you go above the eyebrow with an incision above the eyebrow, small incision, and you mark out the frontal air sinus, so you don't traverse it, and you protect the neurovascular bundle medially, the supraorbital and supratrochlear nerves. And the main key consideration is to drill off the base. You get a flat base. You remove the flat base so that you have a direct vision to the tumor. And ideally, you should not be keeping any patches here, but once you have a lot of experience, you can keep patches. Otherwise, I think it's best to avoid patches when you're drilling here. Again, this one, so you can see that is the base of the optic nerve there, and often then you have to drill off this, the base. That's the problem with the cranial approach. Sometimes you leave it. Here, there's no tumor post-op. She's had to come for follow-up. So in general, just to familiarize yourself with the anatomy of the skull base here. So cella here, you have the tuberculum here, then you have the planum here. The tumors coming from tuberculum or the chiasmatic sulcus or one of the borders of the chiasmatic sulcus, we call the superior limbus or the superior border or the inferior limbus. So tumors can come from all these locations. And these are ideal targets for endoscopic approach, and you have to decide whether you have to go cranially or endoscopically. But tumors coming from the crinoid, they are not an indication for endoscopic approach. So when you look at the various approaches for these tumors, you can either go through the chitinal approach, standard frontotemporal craniotomy, or you can add an orbitozygomatic approach to it. You can go unifrontal through the just subfrontal approach, or you can go bifrontal, mainly for bigger tumors, and you can do a supraorbital orbitotomy. And sometimes you can do you can add an orbital rim, and you can also do a supraorbital mini craniotomy, like an eyebrow incision. There's one more operation which is interhemispheric. Some surgeons follow interhemispheric approach for tuberculum cellular meningiomas, and then you have the transfusional operation. With all these options, you have to decide what the best option for you, depending on the kind of tumor, your own preference, your own experience. The indication and the aim should be very clear. Your aim is to protect or to avoid further damage to the vision. So often you have to remove the optic, the roof, de-roof it, and also transcranially you have to cut the falciparum ligament to look for tumor entering into the optic canal. So in patients with optic nerve dysfunction, 80% of them will have involvement into the optic canal, often medially. And this is a key step. If you preserve the arachnoid, you can avoid damage. And another debating point is whether you go on the same side of the visual loss or the contralateral side. That's another debate. And there will be preference for both. So for example, if you go from the damaged eye, you probably will protect the other eye. But then if you go from that side, the tumor may be going on to the contralateral side. It may be a different trajectory. So we'll leave it at that time. This is another young man, was a porter in one of our hospitals with this large tumor. Even though it's ideal midline, it is sort of going laterally, and also the anticipal arteries was quite attached to it. So I decided to do a transcranial operation for this one. Again, through a standard frontotemporal approach, but it's like a lateral supraorbital approach where you do a bicoronal incision, but the craniotomy is just anterior to your pterion. So you're not going into the temple. It's not a proper pterional approach. You are just staying above the lateral supraorbital margin. And that's the dorsum sella and the carotid. So you get a good view with the optic nerve in between, and you explore everything. You can preserve all the vessels. So the lateral supraorbital approach, without really entering the frontal sinus or even going to the pterional ridge, is a good approach for these operations. Again, he remains well in the follow-up scans. The young computer programmer from Russia, this was in June last year. You can see the tumor here. and the anti-sublunary is attached to it. And the irregularity of the surface also makes it slightly more difficult to do it endoscopically. Again, possibly there is some tumor extension laterally, so that makes it difficult for a total excision. This one again to a lateral supraorbital approach where you do a similar terminal approach, but you stay in front of the sphenoid ridge. This is a young lady. Saw her when she was 16 weeks pregnant, and she had significant visual loss on the left eye. That's a tumor, a tuberculous cellular meningioma, and you can see some swelling of the frontal lobe, which indicates possible prior invasion, which is one of the difficult factors to select a endoscopic approach. And the vessels are encased on it. And she was very clear that she didn't want to lose the baby. She wanted to preserve her baby. So she was willing to suffer from the blindness, which is gradually getting worse. So we agreed. She was started on some steroid by the obstetric neurologist. Again, washed her. Vision started worsening. November. In January, she did have significant visual loss. Tumor remained fairly stable, but you know the pregnancy, they do get some swelling. And eventually, we recommended to the obstetricians to expedite her or bring forward her delivery so that we could operate her. So she had her delivery, and 3 weeks later in February, I decided to operate. So I wasn't sure what kind of operation. Generally, you would go for a cranial given the difficulties, but she's a young female and she wanted to avoid a craniotomy as well. So I decided to go endoscopically here. So this is, the tumor was found to be really tough tumor to operate. It's not a usual soft tumor, and it's very gritty, very fibrous, difficult to get it off the structures around it. The optic nerve I've taken the posterior half of the tumor, decompressed the optic chiasm and the optic nerves. The front of the tumor appeared very resistant. I wanted to show you the anti-subal arteries which are around here. It's very difficult to detach it with the endoscope, so I had to leave part of the tumor behind. So having achieved optic nerve decompression and couldn't get it off the anti-subal artery through the endoscopically, I decided to stop the operation. Again, this is a scan. The flap, you can see the posterior half is all resected. I had to leave that much of tumor. Big cavity, but still a lot of tumor left behind. But her vision gradually got better. In fact, it improved completely. In 3 months' time, she's back to normal vision. Then the scan afterwards shows that the cavity, then I had to take her back to theater for a transcranial operation. So again, I found it difficult to operate through the head as well. The anti-subal arteries were really stuck. Even through a cranial approach, I could not get it off the anti-subal artery. They were so attached to the anti-subal artery. And so I had to leave a little bit of tumor rim around the anti-subal artery. So the attachment to the anti-subal artery makes any tumor difficult. But the rest of the tumor I removed. You can see I had to leave some tumor remnant onto the artery. And the histology was not surprising. It was grade 2 meningioma. They will have more infiltration to normal structures. So there was no wonder that I couldn't really separate the anti-subal artery. And there was a question whether to give radiation to her, but I decided to wait. We're still waiting. So there is a remnant here which is not growing, so I'm watching it. If it grows, she will get stereotactic radiosurgery. This one, another young female, significant visual loss. You can see the tumor is extending quite laterally. You can see the distortion of the optic nerve here. That's the optic chiasm here. The optic nerve is really distorted. Again, this is the one for a transcranial approach. Ipsilateral transcranial route. This one was through a frontal approach, not through a lateral supraorbital approach. So she remains well till now. That's the follow-up scan. So we'll go so I just want to make 2 more points. When you have to decide how complex this is going to be. So Michael Becktermott reviewed all this and graded the tumor depending on the extension. One is the size of the tumor. The tumor more than 17 millimeter or less than 17 millimeter. And the canal score is when the tumor extending into the optic canal. And the third score is the artery score, when it encases the artery. If it is just touching it, or if it is just onto the 180 degree around the medial ICA or the anterior cerebral artery, or if it is all around it, that gives you a grading for the tumor. And then higher the grade gives you more complexity of this operation. Similar grading you can see here. The tumor entering into the optic canal, and that part of the tumor you can take it with the endoscope rather than through the cranial route. So that is not an issue. Similar grading by Motsavi and Shager, but they have included other factors, invasion on the brain MR and previous surgery and previous radiation. These factors will make this complex. So in terms of whether to select endoscopy versus cranial, it's mainly your own experience and preference. You have to decide a lot of factors. One is generally there's no difference. For selected cases, whether you do it cranially or endoscopically, there's no much difference in terms of recurrence. But it's a complex decision process. To me, it's always surgeon's preference and experience. But one other thing is, which I haven't mentioned here, is the tumor consistency. If the tumor is tough and fibrous, you find it very difficult. But it's a more soft and easily removable tumor, you can remove all of it. I think I will stop here. I wanted to show you some clival tumors, but we'll stop with this. Thank you.
Спасибо вам за презентацию. Есть вопросы?
Thank you. Okay, any?
Спасибо за очень интересную лекцию. У меня вот вопрос. Вы когда показали первый случай ваш, там менингиома планум сфеноидали, и сказали, что вы сначала ее наблюдали, а потом приняли решение о операции, когда опухоль выросла. Может быть, стоит раньше оперировать?
That's okay, I got it now. Yeah, I can hear you. What's the question? Yeah.
Вот, по его случаю клиническому сначала наблюдали за опухолью, а потом, когда она выросла, приняли решение сделать операцию. Может быть, стоит, все равно, значит, если опухоль маленькая, то эндоскопический трансназальным доступом мини-инвазивный же метод, поэтому, может, стоит раньше оперировать, сразу же. Вот так вот. Спасибо.
We're talking about this case? This case? So general policy, I always, in fact, generally in UK, what we follow is that if there is no symptomatic issue with the patient, if the tumor is stable, why do you want to operate? The question is, these patients will have regular routine monitoring. We pick up any early change very early on. And you cannot, if a patient is really well, you cannot make the patient any better than what that patient is. So you will always have some issues. Just by opening the head or doing a nasal operation, there will be some side effects. So if the patient is really well, and if the tumor is stable, not causing any major symptoms, we can watch it. In terms of choosing early surgery, you pick it up. If you know that the trend of the tumor is growing, then you know that it's going to grow. But not all tumors will grow. Some tumors will remain stable for years and years. So if the tumor starts showing some growth, then you can intervene. Is that something which answers your question?
А если опухоль атипическая менингиома, то есть злокачественная? В таких случаях вы же не знаете же морфологический диагноз.
So you're worried about possibility of a malignant tumor. Often we can make very good prediction based on the MRI and the nature of the pattern of the tumor and the location of the tumor, that is almost certainly going to be a meningioma. The standard protocol what we follow, when you see a patient first time, if you have any doubt, you will do a close early scan. Often we know that it's going to be meningioma, but you don't know the grade. So the policy for meningiomas, when we see these patients in our skull-based clinic, to get an early scan in 6 months' time, or even 3 months' time if you're worried about some of the pattern on the MRI scan, and then see how it is. And then if the tumor is not showing any change at all in the 6 months or 3 month scan, then you can go for another scan in a year time. But if the tumor is showing change and if you're worried about the appearance, then you would decide for any intervention. But often these tumors, as you know, turn out to be benign tumors. Very unlikely for a malignant tumor to appear like this. If it is a malignant tumor, you would know from the second scan you do.
У меня тоже вопрос. У меня 2 месяца назад точно был такой случай, как у вас. Во втором случае, менингиома плазма, я сам настаивал на транскраниальной операции, но пациентка настояла на трансвеноидальной операции. Во-первых, вопрос, я вот тоже не смог удалить ее полностью, точно такая же, нижнюю часть удалил, верхняя осталась, она сильно кровоточила. Вот первый вопрос такой, насколько правильно идти на поводу у пациента и выбирать его выбор? Я вот сейчас думаю, может, я бы настоял на своем выборе, сделал бы транскраниально. Вот мы сделали МРТ, там опухоль есть. Я предложил повторную транскраниальную операцию, но клинически есть улучшение. Зрение восстановилось пациента лучше. Но пациент опять не хочет транскраниальную операцию. Сама предлагает через 2 месяца посмотреть и сделать радиотерапию, не операцию. Вот как вы думаете, мне как поступить? Как вы поступили, вот, учитывая ваши случаи?
So again, she wants it through the endoscopic approach again. She asking for endoscopic approach again.
No, not again.
Not again.
No.
First time she asked. Already there. Okay. Well, I think you did exactly the right thing by offering her both options and then decided to go endoscopically because she was insisting on endoscopically. So this is often when we speak to the patient, we give the choice of approach and we discuss all the risk and benefits. Ultimately, at least in my practice, the final choice is patient choice. So if they are aware of the risk and the possibility of leaving tumor behind and possibility of potential major risk, and that they still want to go ahead, I would offer them that option if you think it is a valid reason. If you have significant concern, for example, if you think the tumor is going to be really difficult endoscopically, and if you think the optic nerve is affected or the carotid artery is encased, and you would not want to consider endoscopic approach, you have to tell her that. And if you really insist on, she'll have to go and speak to or see somebody else for it. But even though ultimate choice is yours, you have a right to not to do that particular thing which patients want, because they can demand so many things which may not be clinically correct or ethically correct. But if you think that there is an option to either go transcranially or endoscopically, then probably you agree with the patient. And with the second time, she wants to go for radiation treatment. That's what she's asking for, but you want to go transcranially. That's what the question is?
Нет, ну вот сейчас вы мучаете. Может быть, надо было настаивать.
It could have been better, but hindsight is always a good thing. You cannot predict things how it's going to turn up. For example, if the tumor was very soft and suckable, and if you could have removed it very easily, then you would have said that it was the right thing to do. So sometimes you often have to accept what the decision you are taking. and it is not an unreasonable thing to go endoscopically. So I wouldn't worry about it.
Повторную операцию делать или на радиотерапию? Вот вы сделали операцию, потом радиотерапию опять пришлось делать.
So that depends on two things. One, how much of tumor is left behind, and if that tumor is still causing optic chiasmal or optic nerve compromise. And in that case, radiation may not be a good idea. If there is a significant tumor with optic nerve compromise, radiation is likely to damage the optic nerve. So you would like to consider further debulking before you send them out for radiation treatment.
Okay, thank you very much.
Yes.
Спасибо за интересный доклад. Вот возвращаясь вот к этому случаю, к первому, не стоило изначально, когда вы выявили данное образование, отправить пациента в первую очередь на радиохирургию? Не радиотерапию, на гамма-нож, на радиохирургию.
Okay. Take your point. It's often I consider for these tumors, they are surgically resectable. For a meningioma which is accessible surgically, without any major morbidity, your first choice should be surgery. This is what you should recommend to a patient. Really, surgery is an option if somebody who is not well enough to go for a treatment, and or somebody who is really want to avoid an operation. In spite of telling all the risk and the benefits of an operation, they still want to avoid an operation and still insist on having radiation. As I said, it's their choice.
Нет, вы меня не поняли. Я имел в виду, что в первый раз, когда у вас первый раз пациент пришел, вы решили подождать, понаблюдать. Может быть, стоило не просто наблюдать, а отправить пациента изначально на радиохирургию, а потом затем уже наблюдать. Да, конечно, когда уже рост опухоли идет, то, конечно, выбор, скорее всего, в сторону хирургии, когда уже пациент теряет зрение. Вот. Но вот изначально, первый раз пациент вам пришел, вы приняли решение ждать. Но, может быть, не надо было просто ждать, а отправить на радиохирургию в первый раз.
I do not agree because, as I mentioned, the questions, first question, if you have a patient with a tumor which is not causing any problem, you know that it's a benign meningioma, you want to know whether it's growing or not. And as we know, some of these tumors will remain stable for years and years, and they can have their normal quality of life. Why do you want to subject somebody to radiation treatment? And radiation is not without side effect. If you really have to, sometimes radiation fails, and if the radiation fails, then you have to operate, especially if you are operating endoscopically after radiation. The risk related to non-healing of the wound and possible CSF leak higher than a primary case. So I will not recommend a radiation treatment for this patient, but I will agree to patient if they really want to consider surgery, they want to consider radiation as a first step.
Может быть, я снова повторюсь, я несколько не согласен с этим мнением, потому что мы имеем здесь вариант мини-гамматоза. Мы видим, что здесь не один узел, а два узла. И с огромным процентом вероятности, что это опухоли будут расти. То есть вы отправляете пациента под наблюдение, изначально практически предполагая, что эта опухоль будет расти. Имея уже мини-гамматоз, мы видим уже второй узел. Вот, поэтому уж на 90% и понятно, что эта опухоль будет расти.
Yeah, I take your point. Some tumors grow, but some do not. And how long they'll take to grow is also a matter of debate. So this is the scan from 2014 before I decided to operate. She had the tumor from 2011 until up to 2014 stable. So at least 3 years it remains stable. It may eventually grow given the age of the patient. If it was a patient who is over 70 or 80, you know that they may not grow like a younger person. So that is still an option to observe these patients. But I take your point, many of these tumors in a younger patients likely to grow, but not always. But we can have another discussion maybe later on. Any other questions? No?
Спасибо. Нет вопросов. Если нет вопросов, сейчас у нас будет обед. После обеда собираемся здесь на живой хирургии. Еще просят сдать блоки для перевода на зарядку.
Mouse.
Your? No?
Not mine.
Yes?
Yeah, delete. Thank you.